mwenye swali anyoshe mkono. Anyone with a question, please raise up your hand. Yes.
Hi, thank you so much. I actually was asking the question while queuing for the food to the doctor that was telling us about the cost of BMT for sickle cell patients, comparing it to the cost of living with sickle cell disease. Because of course, this is, you know, when we say if treatment is cost effective, we should keep in mind how much money we will not use for what is a chronic disease. So I wanted to know from your research if you have any idea of what is the yearly cost of sickle cell disease in Tanzania, because of course this is relevant. And then to Dr. Siana, thank you so much. Always a pleasure to hear you. Just a comment on the HLA and actually on the non-HLA. Because I think this is particularly relevant for sickle cell disease population, because most probably this is the reason why, or one of the reasons why, when we do transplant from matched unrelated donor, the results are way worse than when we transplant them from haploidentical, you know, parents or brothers. So most probably the non-HLA differences between a matched unrelated donor that most of the time, you know, might be of Caucasian or of different, you know, backgrounds, probably we don't fully capture the diversity. And I think this is particularly relevant for sickle cell patients. So thank you again for raising that topic. Thank you.
Another question?
Oh, thank you, presenters, for wonderful presentations. I will start with my senior brother and colleague, Dr. Soka. As you know, sickle cell, you can be able to do screening for the couples before they start their what. You can do some screening and then you can identify, then you can offer some counseling. Are we there? Are we that? Because the main aim is for us to, we have seen the costs for treatment, they're quite expensive. But is there any role of preventive through screening of the couples before their marriage, so that we can be able to reduce the chances of having patients who end up with sickle cell disease? And if is possible, what are the ethical issues with regards to that? Because sometimes you believe that if someone says that I love someone, it's only heaven and earth that can separate them. This goes to both of you who are dealing with sickle cell disease. Then to my colleague who is coming from NHIF, we know that studies have shown that kidney transplant is more cost effective as compared to hemodialysis. If you make an assessment of dialysis sessions per year for a patient who is getting 3 sessions per week, the costs is more expensive as compared if you could put that patient into kidney transplant and just pay for just the immunosuppressants. Why are you not considering this? Because this will save more money. Thank you.
Thank you.
Asante, thank you very much. So I just wanted to ask or comment in that with regards to the cost of sickle cell disease, there has been research that has been done in Uganda and other countries that have shown that when you do a transplant, it's a big cost, but if you compare it with the lifetime cost, that's a lot. So perhaps that's something that as NHIF you may want to look at, because that will build the case for supporting transplant and other services. The question that I had was whether it would be possible for NHIF, BMH, and other partners, again, to partner with industry. Because if you partner with industry, you're able to negotiate prices of diagnostic tests, you're able to negotiate prices of medication. So I don't know whether there's a possibility of exploring that, because that would be a fantastic opportunity, and if you have any thoughts with regards to that. I think I'm a little bit obsessed with research, because if we partner with research partners, it would really help, and maybe Dr. Siana, you can speak about this, it would really help to address the issue of cost and the issue of access. So there are more comments, and it would be great to hear your reflections, because I'm really keen that we take this forward and address these, because a lot of these issues can be addressed and can be solved. Thank you.
Asante Profesa. Kwa sababu ya muda, nafikiri maswali haya matatu yanatosha. Anyway, wanatengeneza link ambayo watu wenye maswali zaidi wanaweza wakashare huko maswali yao na majibu yatapatikana. Therefore, tuendelee sasa hivi na kujibu maswali. Karibuni. 1 minute kwa kila mmoja kujibu swali.
Can you remind me your name, please? Fabio. Okay, thank you. Let me respond for the first question on the cost for sickle cell disease per annum. Oh, yes. So the one I projected about approximated 10 million per annum without bone marrow transplant. And then the next question is from from Meremo. Okay. You said the cost for transplant in a long run as compared to the cost for hemodialysis. Is it right? Okay. So, as you know, NHIF was health insurance. We used to pay for services after collection of members' contribution. So if we have many patients who underwent renal transplantation at once, we could even paralyze for other services. So maybe I'll take this question. Of course, we understand the costs are more cheaper for transplant as compared to hemodialysis per annum, or even per, I think it's per 5 years. Per 5 years, as I review the literature, I saw the cost of per 5 years if the patient underwent hemodialysis sessions. It's approximated to if this patient underwent 1 session of kidney transplant. So I will take this, and when we reviewed our package, according to the actuarial evaluation, we will make this into consideration. But most of the time, as you know, we pay according to those contributions per month. Thank you.
Okay.
Thank you so much, Fabio, for the comment. And I agree with you that for sickle cell, of course, the case is different from the other transplants where we're dealing with different organs. I think we know from genetics that even siblings are different genetically. They are much, much more similar than other people, but they're still different in ways. The only thing that we don't know is whether the differences that they have significant effects or not, because the differences may have an impact or maybe not, depending on where these differences are sitting and the roles of these genes in relation to transplant. I think it's a good question to follow up with these transplants and do research and see whether we have unexpected outcomes. Is it being caused by differences that these two siblings have or not? But of course, it's more applicable for the organ transplants. And thank you, Professor Makani, for the comment on research. And I think there have been a number of research studies. Maybe Soka can also comment on health economics, in particular for sickle cell disease, trying to understand the cost per patient per year. And I think such studies are really important for a company like NHIF, so that you have enough data which can assist you to make the decisions that are really tangible. Thank you.
Thank you, Dr. Alfred, for your question about premarital screening for sickle cell disease. In 2018, we conducted a study to look on the viability and the prevalence of trait among youths in Tanzania, whereby we screened around 13,000 youths from universities and secondary schools. And the prevalence was 15 to 20. In some regions, like most of the regions in the lake zone, the prevalence went up to 23% of trait. So it's very important to talk of informed decision among our youths. So as a ministry, we disseminated this report to the ministry, and good thing is the ministry has adopted Vunja Mduara as a national strategy for prevention, both primary and secondary prevention of sickle cell disease. And this has been included in the upcoming treatment guideline. There will be a chapter, the whole chapter about premarital screening, health education, premarital screening, and informed decision among youths in Tanzania. Thank you very much.
Okay, thank you. I hope we are through with the question. Anyway, as I've said, we will share a link so that anyone with a question might ask through the link, and we'll get answers through that link also. Okay, na ni washukuru presenter wetu kwa kazi nzuri na presentation zenu nzuri, na kila laheri, karibuni mkakae.
A round of applause to Dr. Baja, Dr. Clara, and the rest of the team who have presented online and here physically. Asanteni sana. A quick announcement for those who are interested in liver transplant. For those who are interested in liver transplant, kindly register your name at the registration desk. A quick dinner is prepared so that we can have a discussion on how to start liver transplant in Tanzania quickly. MOHAS delegates, right after the closure of this session, at the booth outside, a group photo is requested and they should appear at that particular moment. I now call upon Dr. Shija Kesi. Dr. Shija Kesi is a nephrologist from Benjamin Mkapa. He will lead us into the last panel discussion. And this panel discussion will start with Dr. Hidaka, then we'll hear from Dr. Thompson, then we'll hear from Dr. Babu, we'll hear from Dr. Frank Asimwe, and then we will hear again from Dr. Pablo, and then we'll take questions and answers, discuss a few things, and then we'll finish up with the last talk, which is on way forward. Thank you very much, and then we'll go to closure ceremony, where we'll give each other a certificate and a handshake. Dr. Shija, the floor is yours. Continue.
Thank you so much, Dr. Mgisha, for inviting me to chair this next panel. This panel includes various speakers. Among them is Dr. Hidaka, Sumi Hidaka. Sumi Hidaka is our mentor, pioneered in the establishment of kidney transplant at Benjamin Mkapa Hospital. He's working with Tokoshkai Medical Group, the hospital which is called Shonan Kamakula General Hospital. So Dr. Hidaka underwent her training, graduate in many years back, and she is currently a position of a director of kidney transplant services at the Shonan Kamakula Hospital. She trained all of us when we underwent training in Japan, as well as during our establishment of kidney transplant at Benjamin Mkapa Hospital. So she is our teacher. She will be submitting her presentation via a video recorded. So I welcome you to listen for her presentation. Welcome.
Good afternoon, everyone. I am Sumi Hidaka from Shonan Kamakura General Hospital. I regret that I could not travel to Dodoma, so I am presenting via a recorded video. Today, I'd like to talk about how we work together with our colleagues in Dodoma to build a sustainable kidney transplant program. Let me start by introducing Tokushukai Medical Group. Tokushukai Medical Group is the largest private hospital group in Japan. It was founded by Dr. Torao Tokuda in 1973, and today it operates more than 400 medical facilities, including 89 hospitals. Our philosophy is simple but powerful. All human beings are created equal. This belief comes from a deeply personal experience of Dr. Tokuda when he was 9 years old, living on Tokunoshima, a small island in southern Japan. His younger brother became seriously ill, but no doctor would treat him, and he passed away. This tragic experience led Dr. Tokuda to dedicate his life to ensuring equal access to health care for all. Guided by this philosophy, Tokushukai began medical cooperation in Africa in 2003. Our goal was not just to treat patients, but to build sustainable healthcare systems. To make our support truly sustainable, our approach has always been, don't give a fish, teach people how to fish. So instead of just donating dialysis machines, we focus on teaching how to use them safely, maintain them, and run services independently. Since 2008, we have trained 25 teams from 19 countries across Africa here in Japan. The countries shown in red are those 19 countries. Over the years, we have donated 190 dialysis machines to 17 countries. We also train teams on-site in their own countries, using local resources and real clinical situations. This allows us to identify local challenges together and develop practical solutions that fit the local context. Countries highlighted in red represent those where we donated equipment, while those in blue indicate countries where we provided both equipment and on-site training. I am often asked by people in Japan, in a way, this may be a valid question. Is maintenance dialysis really meaningful in sub-Saharan Africa, where so many patients have kidney failure? Maintenance dialysis may benefit only a limited number of patients. However, a functioning dialysis center can save lives, especially in acute kidney injury. For example, a young mother in Tanzania developed AKI after childbirth, but recovered with dialysis and was able to raise her baby. This is why I believe this work truly matters. In 2016, the government of Tanzania formally asked Tokushukai to support the initiation of kidney transplantation. This marked a turning point from dialysis support to transplantation. A few months later, my supervisor, Dr. Kobayashi, from Tokushukai Group, visited Dodoma and met Parliament Secretary, and the Vice Chancellor of the University of Dodoma. Following the principles of the Declaration of Istanbul, they strongly urged the creation of legal frameworks to prevent organ trafficking. They also confirmed governmental commitment to financial support for immunosuppressive therapy, essential testing, and transplant surgery. Since January 2017, we have been working together, conducting on-site training and inviting staff to Japan. We were preparing for the first transplant in November 2017. But things did not go as planned. Our first major challenge was human resource development. Kidney transplantation requires strong teamwork across multiple disciplines. We identified gaps between existing skills and those required for safe transplantation and addressed them one by one together. This step-by-step approach helped build a confident, well-coordinated local team. Beyond human resources, we faced several practical challenges. Even in early 2018, many issues remained. Essential surgical supplies and medications were not available locally, so we had to bring them from Japan, requiring time and careful coordination. Most laboratory tests, such as HLA, typing, DSA, and cross-matching, had to be outsourced, often causing delays. The ICU and operating room were also not fully prepared. As a result, we postponed the first transplant by 4 months and set a new target date, March 22nd, 2018. In the laboratory, we were able to perform flow cytometric cross-match and lymphocyte subset assays. For example, after administering rituximab, we monitored CD19 positive cells, and if depletion was incomplete, additional rituximab was given. Next, the operating room. 8 days before surgery, almost nothing was in place. Equipment only began to arrive 5 days before. We had to prepare everything rapidly for March 22nd. Flexibility and strong teamwork were absolutely essential. The ICU also prepared challenges, including limited oxygen supply and unreliable section. After intensive preparation, the first kidney transplant was successfully performed on March 22nd, 2018. Without a warming blanket, the patient became hypothermic due to large volume of fluid infusion, leading to hypotension. Seeing fast urine output at 17:30 was an unforgettable moment, rewarded for all the effort and dedication. This historic procedure was carried out by a Tanzanian team for Tanzanian patients. By January 2020, 11 kidney transplants had been performed with support from Japan over 4 visits. Today, the Tanzanian team has independently performed around 60 kidney transplants. This demonstrates the power of long-term partnership and local leadership. We have also translated our experience into scientific evidence, quality and sustainability. This journey represents a transition from support to sustainability to now supported by evidence. In 2025, Benjamin Mkapa Hospital and Shonan Kamakura General Hospital were selected as an International Society of Nephrology ISN Sister Renal Center pair. This designation will further strengthen training and capacity building in renal care at both centers. Building on the growing expertise of the local team, Tokushukai President decided to launch a project to establish the Kidney Disease and Transplant Center in Dodoma. This center is designed to serve as a regional hub for kidney disease prevention and treatment across sub-Saharan Africa, with the goal of improving health outcomes across the region. As a nephrologist, I also hope that this center will provide comprehensive care, including not only kidney transplantation, but also active management of glomerular disease, such as therapies incorporating apheresis. I would like to summarize why this project succeeded. It was guided by a strong philosophy: all human beings are created equal. We focused on long-term capacity building rather than short-term support. We worked as a multidisciplinary team with strong local and governmental collaboration. We addressed challenges together under resource-limited conditions. As a result, the local team was empowered and the program became sustainable. It became a Tanzanian program for Tanzanian patients. Finally, I'd like to briefly describe the current status of kidney transplantation in Japan. In 2023, a total of 2001 kidney transplants were performed. This growth has been driven mainly by an increase in living donor transplantation, while deceased donor transplantation remains limited. Contributing factors include more transplants from non-related donors, the expansion of ABO-incompatible transplantation, and the use of older recipients. However, overall transplant numbers remain low compared to the growing dialysis population. Dialysis is here. In Japan, due to the shortage of deceased donors, the proportion of ABO-incompatible living donor kidney transplantation is relatively high. The national average is 30%, whereas at our institution, it is 40%. This is our institutional protocol for ABO-incompatible kidney transplantation. In addition to the standard regimen for ABO-compatible transplantation, we perform 1 or 2 sessions of plasmapheresis and administer rituximab at admission and the day before transplantation. In our data, there was no significant difference in patient survival between ABO-compatible and ABO-incompatible kidney transplantation. Similarly, there was no significant difference in graft survival between ABO-compatible and incompatible kidney transplantation. So I have presented Tokushukai's support for dialysis and kidney transplantation in Dodoma. I also discussed ABO-incompatible living donor kidney transplantation. With appropriate pre-transplant desensitization, favorable postoperative outcomes can be achieved without increasing the risk of infection. I sincerely hope that kidney transplantation at UDOM and BMH will continue to develop safely. And finally, I'd like to emphasize the importance of careful long-term follow-up of living donors' renal function. Thank you for kind attention. Good afternoon.
Yeah, that's a wonderful submission from Dr. Hidaka Sensei. We do appreciate for their passionate and the resilience for the difficulty that we went through while we were establishing kidney transplantations, and we are looking forward for more collaborations, and this makes it more important in partnership with a strong partners. So let me again go to our next presenter, who also will be submitting online submissions, is Professor David Thompson. Professor David Thompson works at the Division of Critical Care and Heart, Head of Transplant Center of Excellence, University of Cape Town in South Africa. He's a critical care specialist and abdominal transplant surgeon at the Groot School Hostel and the University of Cape Town. He focuses on medical education and improving disease organ donation system, developing key training programs. He has held leaderships role in regional and international transplant societies, contributed to the global initiatives and the latest South African donation strategies and the national death determination guidelines, while heading a transplant center of excellence project. Warm welcome, Professor David, for your submissions, online submission.
Thank you very much for the kind introduction. Can I check that you guys can see my slides and you can hear me?
We can hear you, sir.
Perfect. Well, thank you very much for the invitation. It's a great honor to be speaking to you today. And I think what you'll get from this talk is that there's a lot to unpack in this space, and you can't do it alone. It's a collective effort. You gave me a too flattering title, Learning from Giants. I think South Africa is in a privileged position historically, but we engage with many of the challenges that all countries in Africa face related to improving access to donation for disadvantaged people. And it is a system reflection. So I'm going to try and take you through some points. And I will go through quite a lot of slides quite quickly, but I'm happy to share these slides afterwards, and please do reach out and make contact afterwards, because it is a lot. My position is I'm an abdominal transplant surgeon, but also a critical care specialist. So I span the ICU setting and end-of-life care, and my career trajectory has really focused on trying to engage around deceased donation. Now, what happens in countries developing transplantation is that it invariably is starting with living kidney donation. But I see from your program you have corneal donation on the agenda, and you'll see that theme does come through in my talk. And we do have deceased donation in South Africa. But I've got no conflicts or disclosures for this talk. But human mortality is still 100%, despite all the doctors and nurses and all the team effort in the room. And we need to acknowledge that donation is actually about trust. It's not purely an education, and especially for an emotional family, it's actually about trusting the system, and it's how we do that. And just acknowledge that in that emotional moment, we have to get that establishment of trust. The dead donor rule, for me, deceased donation is really paramount, that this will always stay in place. All organ donors are clinically dead before organ removal in terms of the deceased donors. And what we teach to the school children here is, well, we'll only donate an organ when you don't need it, and only with permission. And those are the two absolute paramounts for donation to take place. The other part to realize is it's really important that the transplant team's not involved in a decision to palliate someone, okay, in terms of compassionate extubation or the certification of death, okay? But that does not mean that they can't be contacted to inform people and integrate into the end-of-life care discussion so that donation is an option that's offered to the family in the best way possible. Just in terms of the scientific element, in terms of declaration of death, and this is why I prefer to operate on deceased donors, because there is no risk to the donor. Living donors are the only operation I would ever do when the patient doesn't need it for themselves, and it's incredibly stressful. And we can do it safely if we do it well. US data is 1 in 10,000 living donors would pass away for kidneys. It's higher for living donor livers. But for deceased donors, there is no risk to the donor. Okay? There's a family to support through the process. And just to say that scientific determination, okay, is only one part of the process. And if we're going to go and engage about consent, it's linked to how we communicate and compassionately handle end-of-life care with the family. And if a family does not understand brain death, it's not a lack of knowledge. Communication and empathy. It's actually a failure of us to engage with their emotional state that is probably the primary reason for families not able to move on to acceptance. And we need to acknowledge that communication is a skill that we have not taught well in our undergraduate and postgraduate curriculums. We consider it soft and we don't unpack it as well as we could. So there's a couple of ways to be certified dead. There's neurological criteria. That's what we know as brain death, okay? And actually when we teach this, if you can just say to someone, but they are dead on the ventilator, why are we complicated by trying to make it brain death or brain stem death? It is a way of determining death and that permanence that gives us the complete confidence that anything we do after this would be medically futile, and therefore we must stop and move on to the next part of the process in the patient's journey. You can also declare death on circulatory grounds, and there are also somatic criteria for death. So it's circulatory, neurological, and somatic, okay? And that's what the paramedic would use, recognition of life extinct, and we don't need to do futile medical procedures when we have certified death. And that's a public health need, okay, to certify death timeously, and we have that obligation in the ICU as well. It gets harder when it's communicating futility, because then we don't have that complete certainty, but we do need to realize when our medical interventions aren't able to give a meaningful chance of survival, and it should not be until the funding runs out. So preferred terminology is brain death, not brain stem death, or circulatory death, so not cardiac or cardiac respiratory. And how did we get here? Well, we've been through one pandemic, but there have been other pandemics, and there you can see them ventilating at scale in the polio pandemic, and that was in 1952. In 1959, we realized that there's a whole subset of patients on ventilators who are not neurologically active in any way, shape, or form, and we started to define what that is. And that let us go into an end-of-life care pathway. And it's quite important that we do not link brain death determination to transplantation. Brain death determination is an end-of-life care process that allows us to talk to the family about futility. It's not we're doing this purely for donation. We should be doing this for good end-of-life care. And we often see the picture of the first heart transplant, and that looks wonderful, but actually for me it's much more about who gave permission. And was it the father of the donor or the mother of the donor? And in this situation it was actually the father, because the mother died in the same accident. And we can just imagine what that was meaning and how you need to engage with the family and support them at that point. Japan followed on after the South African transplant in 1967, and it's really important to realize that they had a moratorium on this afterwards because the doctor involved in the operation was involved in the certification. And it's really important that we split those two responsibilities completely separately. And South Africa's been, we're leaders, but we're actually quite fortunate because what actually happened with our legislation is that it mandated the separation, but it didn't stipulate the medical standards that it had to be done to. That was left to the medical professionals to decide upon, independent of a parliamentary or legislative process. And I'll give you an example of an EG. So quite a few countries actually legislate, well, we need extra certainty, so let's put into law that you need to use an EEG to certify brain death. That reduces access to being able to determine brain death accurately because you now need an EEG technician to do it. and it is actually a 70% sensitive and specific test. So it's actually pretty rubbish in terms of determining a brain death diagnosis. But there are many jurisdictions that legislated this, and they're still trying to walk it back. So on a legal level, South Africa was really lucky. We acknowledged that brain death is death, so we acknowledged that. And then we said it has to be independently certified in cases of organ donation, separate from the transplant team. And then the degree of experience we settled on, okay, was not you need to be a qualified subspecialist neurologist. It was one doctor with 5 years experience and another doctor, okay? And then we also always need informed consent from the family. We need authorization from the medical manager where the recovery takes place, and we need medical authorization from the forensic pathologist that we're not interfering with their processes. And then what standard are we held to? We're held to a reasonable medical standard. Now that's actually a little bit of a challenge, okay, and I'm not 100% sure. I don't think there are Tanzanian rules or regulations in place for this. And if you look at the professional guidelines, there's a lot of variability, even more in the children. But at the heart of all of these is that no one has ever recovered from being correctly clinically certified brain dead. You'll read about it in the papers. That's probably a breakdown in communication, okay, or someone has said something and there was a confounder present that actually invalidates the testing. And there was a recent effort through JAMA and a whole world collective to try, and I was lucky to be a part of this, to try and standardize those criteria across the world. But now with recognizing the interplay, but what is the minimum medical standard? And we actually went through a process using that very effective literature review of 130 pages of articles, all reviewed on the latest standards, and we adapted them to our legal context here. So even though the medical standard is one doctor could certify brain death, because if he does it properly, it's valid, but our legal standard, as I mentioned, mandates that it's 2 doctors, okay? And the minimum standard, and just to say, there's a focus on clinical determination. And my slide set doesn't let me move unless we acknowledge that it's actually a clinical determination. All ancillary tests are a single picture, and they can be fooled, okay? And it's a simple checklist, and we've got advice sheets related to that paper, and this has been really useful to help set the standards. And I'm now going to go very fast through these slides because I'm not going to go into the academic part of this, but we need a cause known, we need to adjust for the confounders, we need to make sure that there's no drug effects and any other preconditions in order to be able to make sure that clinical testing is valid. How do we exclude drug effects? You need an approach in that space. You need to realize that metabolically you need to control, but not to complete normality, within a range where it wouldn't mimic brain death. You only need to look for crazy diagnoses when you don't have a primary diagnosis. A CT scan does help, and it's all about the testing. And if you use a checklist, doctors will do it better. Here you can see our checklist with two sheets, and the doctors can do it together. They don't have to do it separately, and they can double check each other. And we've got advice sheets on how the specifics are actually done. The doll's eye test is out of the guidelines, that you can't do on a C fracture quadriplegic. Atropine test will impact on future assessments of the pupils, and it's hard to standardize, so we don't include that. And then the final test is obviously that the brain is not even able to make the body trigger a breath in any way, shape, or form in the setting of an acidosis. Okay, so then you go through a process where that's happening. There are challenging clinical situations. The majority can be certified that way with the clinical checklist, but there are certain examples where you wouldn't be able to do it and you need to use some additional testing. ECMO is a challenge. Our guidelines say if there's a spinal reflex, then you need to do some extra testing. That is incredibly difficult to interpret. It may well be a spinal reflex, but you can imagine emotionally for a family how challenging that is to process. We are letting the families watch the brain death testing, and that also does help for their understanding. Ancillary tests, like I said, are a static picture, so they can be fooled, but they do try to definitively show no blood flow into the brain. Here you can see a radionucleotide scan. 10% of patients do have some blood flow, even though they are brain dead, because their neurons are dead, but there are some preserved blood flow, but the majority of patients wouldn't have it. Transcranial Doppler is difficult to do, and EEG is challenging in that setting. And now we've covered only 1% of deaths. And I think we mustn't link organ transplantation to purely brain death diagnoses, because actually around the world, donation after circulatory death and a compassionate extubation for futility is an established medical pathway, and for me is a big focus in South Africa where we can do better, because we are actually not able to communicate this well to the families, and you need to be able to communicate it exceptionally in order to be able to support donation. So here you can see there's also variability in that testing, and if you look around the world, various countries take various time periods to do this. Italy is 20 minutes, Germany is 4 hours, and you need a checklist that it's inappropriate to do CPR for a circulatory death determination to be permanent. So we have that, and then we would wait 5 minutes, and we do make sure that the ECG monitor's off, because actually that can depolarize for up to 45 minutes afterwards. So here you can see a donor pathway, donor identification, referral, informed consent, and it used to be, well, the treating team needs to do the identification and the referral, and the transplant team does the informed consent. But actually, if you do a DCD program, then you need to integrate all of this together. And that's much more important, that actually you notify all deaths that could be potential donors, and you collectively review them and make sure that this is a quality of care that's offered to everyone. And we found that when we did a study here, that even though patients were referred to as brain dead, they actually needed immediate resuscitation, because the clinical team is not keeping the blood pressure going in order for us to counsel the family and include them and give them a chance to say yes. And also, they weren't aware of a poor prognosis for a brain dead patient in 43% of the time. If we haven't communicated the prognosis to the family, we have no chance to get consent. So it's one of those things, and you need to engage with your clinical teams in end of life, because this isn't something you parachute at the end selectively. You have to want your ICUs and your ED doctors to be supporting it. And it's interesting, different countries have tried to make this a responsibility of the hospitals, rather than individuals. And then you may have a resuscitation council in your hospital reviewing the CPR episodes, but actually reviewing the end of life as a committee is also something you can do. And then you can hopefully create a culture of donation. And I mentioned the answer to this question earlier, and I hope you're aware of it. It's looking like, oh, that couldn't be an organ donor. But I didn't ask about organ donation. Could have been a corneal donor. And then you have to engage around the humanity of engaging with the family and supporting them through the process. So you can donate corneas, and these guidelines are actually changed. So you need to pick up the phone and check what your local environment is, because it changes all around South Africa depending on where you are, what the quality of the microscope is assessing the corneas. So we try and teach that you could donate anything, and you must clarify the potential for donation with referral. And we're busy trying to set up systems to support that. And here's another example. Could have been a donor to help other people, okay? And then also just to say, like in this scenario, this is one I use for the students, if they don't accept brain death, but actually what would you do in that setting? You would compassionately take away the ventilator, because it's unethical to carry on futile treatment, and then the heart would stop. And if the family acknowledges that death has happened when the heart has stopped, it is actually possible to donate donations after a circulatory determination of death in that situation. And as I mentioned, UK data is now that more than 50% of donors are in this space. It's quite hard to teach, and we're trying to teach it like the ATLS, ACLS courses now, with an in-person course where we actually do simulations and discussions on the whole process, because there's a lot to conceptually take in. And then just a couple of words to end off this talk in terms of how you structure your system, because we're doing this in quite a lot of silos, but deceased donor system organization, blood and tissue and organs, do we put it together? Do we put tissues and organs together? Do we leave it as a hospital-based system? And if you track activities around the world, we have a hospital-based system, no central coordination, 1.6 donors per million population. Spain gets 47. They're the best in the world. UK gets half as much. They spend the same amount on healthcare. Brazil, same level of inequality as South Africa, 10 times better than us. And the USA, with a different model of outsourcing it to individual companies that are mandated, the hospitals have to have a contract with an OPO in order to get paid by the government, and therefore the OPO has to deliver and report statistics. That model will get them to 31.7. Kenya's actually got a very good policy document. I really like this, and we've got it on a provincial level in South Africa. The American approach is unique, but they do have a lot of professionalization, and have looked at the sustainability of those organizations. But when you do it like that, this is the state of Texas. You can see they've got 3 organizations in competition with each other with quite a weird distribution. Just to say one thing about the consent system, please don't ever get distracted by I need to legislate opt-in and automatically make people donors, and that's why Spain is the best. It's not why Spain is the best. Spain will automatically assume someone's a donor, but they will always ask the family. If the family says no, you do not proceed. No one is proceeding if the family is distressed by you taking organs from their loved one, regardless of your consent system. So it's a little bit of a smokescreen that the politicians like, and we like to blame the families for not supporting donation, but we really need to look at ourselves as a healthcare system for why is our end-of-life care not offering organ donation to everyone? And actually, Spain's good because of these things. They put their coordinators in good end-of-life care into the ICUs and quality assured the process. Australia was also underperforming, so what did they do? They did two things. They made routine notification and made it a team effort to approach for consent. And those made a big difference in Australia. This is coming, I mean, Nigeria, I know Ibam's talking on your conference, and the legislation's almost in place, and we kind of need the confidence to move into this realm across Africa. It is about education, and these are two teaching resources. The one on the left is our certification documents, the one on the right is our in-person course, and we've actually got an online course that we've managed to spread from our university to all the other universities to help teach the medical students about donation with online videos and MCQs, and that's been a good method to standardize it, because actually in South Africa, 5 medical schools don't have a transplant unit attached to them, and no one was teaching donation or any of these state-of-the-art end-of-life care processes. So we need to expose everyone to that, because actually everyone who's exposed to an EC where we are, and we're all going to come across death in our end-of-life care pathways at some stage, even if we become an ophthalmologist, it can happen. So we really need to make sure we train well in that space. So I know I've gone over time, but thank you. We can be trusted if we do things right, and it's really exciting to see transplantation move in Africa. And I do think one of the directions is in deceased donation, and that's probably why South Africa is a leader in that space in Africa. But it's a challenge. It's low performing, but I think with an approach to improve end-of-life care, we really can make it better. So thank you very much, and I'm happy to take any questions. Might be easier to type it in. The sound's not so good for me to come through here, but thank you very, very much.
Thank you so much, Professor Thompson, for wonderful presentations regarding the disease donations.
Are there any questions?
Yes, we reserve the discussions after. Discussions on the challenges regarding disease donations, and as well as the setup of the system for the disease donations, as well as opt-in, opt-out, to decide who to give donations to a diseased kidney after death. So the delegates will ask you questions after the next presenters, who is Dr. Babu.
That's fine. I must just step into the ICU to touch base. When do you want to come back for questions?
So in a couple of 15 minutes, we'll be finished with the presenters, and then we'll ask you to join us for the discussions. Is it okay? Oh, someone is communicating with him. Can you? Okay. Thank you so much, moderator. So the next presenter is Dr. Babu. Dr. Babu is a liver transplant surgeon, a gastroenterologist and a liver transplant surgeon. He's working with Apollo Hospital. Dr. Babu is a liver specialist at Apollo Health City, Jubilee Hills, Hyderabad, with over 8 years of experience in hepatobiliary surgeries and transplantations. He holds MS and MCH qualifications along with a liver transplant fellowship from Medanta. He specializes in living donor liver transplantations, comprehensive liver disease management, and post-operative care. He is committed to patient-centered, evidence-based practice, actively engaging in research and academic forums, and regularly participates in national and international conferences to remain at the forefront of his field. fluent in English, Hindu, and Telugu. He effectively serves a diverse patient population. Welcome, sir.
Yeah, thank you for kind introduction. I'm very thankful for giving me this opportunity. Dr. Mugisha and all the dignitaries from Ministry of Health, Tanzania, and the doctors from Benjamin Mkapa Hospital. So, we'll have a 10-minute journey in brief about the concepts of liver transplantation and types of liver transplantation. Since it is a huge topic, definitely I'll try to restrict myself to 10 to 11 minutes. Please stop me if I overshoot. Okay, so coming to the liver transplantation, current practices and new developments, I'll also be giving the picture of current picture in India. So Thomas Sturgill, we all know, he's the father of liver transplantation. He conducted the first successful liver transplantation in the year 1967. Because of his hard work, that's how we are here, and all the countries started doing transplants. So we'll be discussing about broadly the liver transplantation methods, outcomes, and also few aspects of living donors, and the standard recipients and complex scenarios. Standard recipients, the reason for doing liver transplantation might be chronic liver disease, or acute and chronic liver failure, or acute liver failure, and also liver transplantation for various indications in pediatric liver transplants. In the recipients, there might be advanced hepatocellular carcinoma where we have to downstage, and there are complex scenarios where we need to tailor the things and then proceed. Coming to India, approximately 50,000 liver transplants are needed in India. When the programs have started in India way back in 2003, 2004, year 2003, 2004, hardly 50 transplants used to happen in a year in India. But the requirement is 50,000 liver transplants are needed in India. Currently, India is doing approximately 3,000 to 4,000 transplants in a year. So the remaining 46,000 patients are dying without liver transplant, without timely liver transplants. So India has become currently the leading nation in the world in conducting living donor liver transplantation. As I said, India is doing around 4,000 to 4,500 liver transplants in a year. There are some centers in India doing 450 liver transplants in a year next to Asan Medical Center, Seoul. So of the 4,000 liver transplants, like any other Asian country, India is also largely depending upon the living donor programs. It's almost 80% of the transplants are living donor liver transplants. Various indications, as I said, they are different in adults and pediatric age group. In pediatric age group, the most common indication for liver transplantation is biliary atresia, followed by Wilson's disease. So, living donor liver transplants, where a family member, a first-degree relative, donates part of their liver. It's almost in an adult like 60 to 70% of their liver. That is living donor liver transplantation. Deceased donor liver transplantation, where there is an organization, NOTO or Jivandan, regional organizations also, state-wise. We need to register and stay in the wait list. So, orthotopic liver transplantation, why I use the term orthotopic? Unlike kidney transplant, where kidney is not removed, but in liver transplantation, we need to remove the native liver, native damaged liver. In the same place, we implant the new liver. That's the reason it is called orthotopic liver transplantation. The first picture is DDLT, deceased donor liver transplantation, where we replace the liver cirrhotic liver with whole liver taken from a brain dead donor. The next picture is living donor liver transplantation, where we implanted half of the liver taken from the living donor. That's the reason we have a cut surface in this picture. Overall, the outcomes after liver transplantation, India to begin with had difficulties when the programs have started. In year 2002, 2003, 2004, the success rate of liver transplantation in India, like any other country when they have started programs, was 10 to 20, 30%. Now India has achieved, in a standard recipient, we are able to give a 1 year survival of 93% and 5 year survival of 80% compared to Western countries. Even in high risk groups, high risk categories, where the complex scenarios are there also we are able to give a overall 1 year survival of up to 70 to 80%. But we selectively choose complex patients after optimization. So coming to living donor, 18 years is the minimum age for a donor to donate. Apart from the basic blood test, we do a CT scan to look for the volumes of the graft and remnant liver. Future liver remnant, the minimum future liver remnant, safe remnant in a living donor. In women, in female donors, we keep at least 28%. In male donors, 30% future liver remnant we aim. This is how we evaluate all the living donors, doing a triphasic CT scan, looking for the volumes, arterial anatomy, portal venous anatomy, hepatic venous anatomy, and an MRCP to look for the bile ducts. Recently, it's our research project. I presented in ILTS Rotterdam and also in Istanbul. We are publishing this. We are adding a functional liver study, that is hepatobiliary scintigraphy in nuclear medicine. Apart from CT, we also regularly doing hepatobiliary scintigraphy to look for the functional capacity of the liver. CT gives the anatomical volumes or morphological volumes, but our scan also gives additional information of the functional capacity of the liver. What is functional capacity? Probably at this stage, it tells us the actual quality of the liver. Probably it might be a surrogate marker of regenerative capacity of the liver. We need, like in an automobile where there are difficult roads, we need a good automobile engine, the way we need a very good engine to get through the difficult roads, where if the roads are steep. Here also, we need a very good liver, both in donors and as well as in recipient. Both donor surgery is stressful surgery, and also in recipient, especially in living donor liver transplant, where we implant partial liver. It has to regenerate so fast and need the metabolic demands of the recipient. So what is the graft size required in living donor liver transplants? It is according to the body weight of the recipient. For an adult more than 40 to 50 kilos, the standard graft is right lobe. In small adults around 40 kilos, we can get away with left lobe of the liver. In pediatric recipients, we need either left lobe, or kids less than 10, 15 kilos, we can use two segments, that is left lateral sector grafts. Yes, all the surgeons here and anesthetists and OT staff, looking at this picture, it tells us how the difficult surgery would be the recipient surgery. This is about a standard recipient. We prepare with 10 to 15 units of blood products and platelets, SDPC, at least 3 units. So we need to be geared up to meet the blood requirements. All the recipients have the tendency to bleed because of portal hypertension and liver disease associated coagulopathy. The outcomes and recipients are multifactorial. It might be donor related, graft volumes, quality of the liver, and how we conduct the surgery, and pre-transplant recipient condition, the MELD scores and associated sarcopenia, and how meticulous we are in operating or while implanting the graft. Need to take care of both inflow and outflow. And also the post-operative issues, mainly sepsis, rejections, some kind of graft dysfunction or non-function, all these things we need to take care. So liver transplantation is, thank you, I'll be completing. So the duration of surgery is around 10 to 12 hours in living donor liver transplants, and deceased donor, it is around 6 to 7 hours. This is how a recipient abdomen looks like. This is the standard recipient, a cirrhotic liver, vascular adhesions. So we need to take out this damaged liver and replace with a new liver. So coming to the complex scenarios, here is a recipient. He was 120 kilos. Initially, wife came forward, but she couldn't donate a big chunk of liver because the recipient weight was 120 kilos. So brother also came forward. So here 2 donors have donated. Wife has donated right lobe and brother has donated left lobe. Combined graft volume was 800 grams, and we could organize this called dual lobe liver transplantation. Here you can see the right graft is donated by the wife and the left graft is donated by the brother. This patient we could discharge in 12 days and is doing well. And dual lobe liver transplant was, this transplant was organized in year 2023, and this was the first transplant in our state in Hyderabad. So another graft is right posterior sector graft. Here the standard graft, that is right lobe, cannot be donated because of inadequate future liver remnant. So we could take only the posterior sector, that is segment 6 and 7. And it was a very difficult, technically demanding liver transaction because we had to take only segment 6 and 7. This is the recipient and the donor both doing very well, and recipient is back to his profession, is doing well. Coming to very small recipients, pediatric age group, we need to tailor, we need to hyper-reduce, or we have to take monosegment grafts. And hepatocellular carcinoma, as long as the carcinoma is within the criteria Milan and UCSF, we can achieve the same survival rates compared to transplants done for non-HCC indications. When there is an advanced hepatocellular carcinoma, we need to downstage. The downstaging modalities mainly are transarterial radioembolization or sometimes immunotherapy. This is the patient who had portal vein tumor thrombosis. We did tear and we could sterilize the tumor in the portal vein, and the alpha-fetoprotein has come down to less than 100, and we could do the transplant, and it's doing well. Another mode of downstaging modality is the systemic therapy with immunotherapy. Here also you can see the alpha-fetoprotein before starting immunotherapy was more than lakh, and it has come down to single digit at the time of transplant, and there's no recurrence, and patient doing well after 3 years. This is the PET CT, see how it was lightening, and just before the transplant, there was no tumor at all, and on histopathology, there was complete resolution with immunotherapy, sorry, in selective patients. So immunotherapy is making miracles and enabling patients who are otherwise unfit for transplant, we are doing. And this is the patient, daughter has donated, and it is 3 years, no recurrence. So ABO incompatible transplants like kidney transplants with the same desensitization protocol, we are doing ABO incompatible liver transplants. We are not doing plasma exchange nowadays. With the immunoabsorption technique with glycosol filter, we are reducing the titers and going ahead for transplant. The advantage is a single session of glucoabsorb filter is enough, no need for further plasmapheresis. Machine perfusion, yes, currently because of extra expenses, and India we are doing only DVD donors. We are not started DCD. When we start DCD, then definitely machine perfusion is needed. This is how the quality of life in a recipient before transplant and after transplant. So this was the child PFIC disease. child has pruritus. The main symptom was pruritus, unable to sleep, and child is doing very well, is playing actually. Oh, sorry. So this is how a sister has donated to her sibling. Primary sclerosing cholangitis is doing very well. She is the donor donated in the year 2019, and she has participated in the Olympics and also got a medal. So that's how the quality of life for the donors, they do really good. They need recovery of time only 3 months. After 3 months, they're like any other normal human beings with full capacity. So this was the first transplant we did in Iraq last year in the month of November, and the patient is doing well, and we are in collaboration with Ministry of Health in Iraq. So this is our team. We have cumulative experience of more than 4,000 transplants, and individual surgeon has an experience of more than 2,500 transplants. I'm in liver transplant field, core liver transplant field from year 2010. Thank you. Thank you so much for listening.
Thank you so much, Dr. Bab, for the wonderful, well-experienced discussions and presentations from Apollo regarding liver transplant. So to this point, I think also Tanzania can do liver transplant. Thank you so much. So our next speaker is Dr. Frank Asimwe. Dr. Frank is a president of Uganda Medical Association. He is a urologist, had several training, including fellowship in advanced urology and renal transplant surgeries. He is a consultant urologist and a leader transplant surgeons. He also a consultant general surgeons. He is the chairman of urology and organ transplant in Mulago National Hospital. He is associate clinical professor, surgery of a honorary professor in King Sestra University, KSU, and also is a director of FCS urology training at Mulago National Hospital. Welcome, sir.
Thank you very much. I want to thank the President of Tanzania Medical Association for inviting me. Frank Asimwe are the two names which I can say and you understand. The others are long. I actually have a conflict of interest, which I must declare. I cut my teeth in urology in Tanzania. I did my training in urology at KCMC. And as soon as I returned to Uganda, they asked me to head the transplant unit. And I was first trained by the team from Tokshikai. So I really feel attached. And after that, I was trained by a team from Yashoda, and my colleague here told me he worked partly in Yashoda. So I'm really conflicted, but it's a good conflict of interest. In the interest of time, I'm going to skip some of the details that have been shared. That has been shared, the burden of disease, but just to emphasize that end-stage renal disease, if untreated, 100% mortality. To make a case for transplant, it frees up the patient. Dialysis, fairly good, but you are tied to one place. And as we've been told, the cost is also lower. The technical details, you all know. We concentrate on the right iliac fossa, at the same time the left iliac fossa. Venous anastomosis, arterial anastomosis, and uretrovesical anastomosis. That is our team. That's myself, my colleague Dr. Namuga, and the transplant nurse. The journey, the global journey, you know, 1902, the first experimental transplant in canines, but the jinx broke in 1954 by Murray, successful transplant between twins, and the rest is history. What's the Ugandan journey? We want to take this journey to as far as the time when renal care began getting isolated from the rest of the care. When you have people being isolated from physicians and they take up the trade of nephrology, and I'm saying this emphatically because transplant, without the nephrologists, we are wasting our time. And fast forward, without an established dialysis unit, you're also wasting your time. It is the first renal replacement therapy, and it is a must-have if you are to have a successful kidney transplant. But for us, our journey began in 2013 when we partnered with the Yashoda team, and who took us through several things. They began training us. They helped us with setting up our infrastructure, and they helped us to come up with the Uganda Human Organ Donation and Transplant Act. Very important. So even before we did our first transplant, we already have a law which covers living donor transplant and deceased donor transplant. Our maiden transplant was in 2023. We did our very first one. Young man, he's still happy. And finally, we have since done 15, and in the partnership, we have had the Royal Manchester Infirmary. And I want to slow down and tell you and our partners, Africa has come of age. The time you expected us to send patients to you is coming to an end. The time you made us a camp site, prepare patients and I come and do, has come to an end. You better teach us, and we do it ourselves, okay? Those who don't want to teach us, your time is running out. You have heard, I am a medical politician, and now Africa is able to teach itself, and I will be telling you how. The program has only run because of several blocks. The legislative structure, very important. For us in Uganda, every transplant must be authorized by a central organ transplant committee. You can't say we have done a transplant without them knowing. Infrastructure, very important. The theater, the ICUs, the dialysis unit. The partnerships, I've already mentioned. Multidisciplinary teams, I cannot overemphasize this. Urology, nephrology, nursing, anesthesia, and the team abroad. Very, very important. And then the training. We have had a hybrid training model where we go to India, spend about a month and a half, and work. So we work in India, we work in Manchester, we see in the best centers, then we come and work in our own area. That hybrid has worked for us. And of course, public engagement, very important, talking about the partnerships. This is a picture, it's a recent one, but that's the Yashoda team that we partnered with, and then also the Manchester team. We have had political will. Getting a picture with this old man is not easy. That is him, and that is me. But sometimes translating the promises he makes on the ground can be very difficult. But you need political will. I have no doubt that there is political will in Tanzania. Succession planning. In case I'm going to disappoint you, I am 54 years old and I'm about to retire. Sorry, in case you thought I was 20. And that's me. My colleague is 50, Dr. Joseph, but between the two of us is Dr. Job, who is only 40, and Dr. Martha, who is 30, and there's another Dr. Badru. So we are sure that even if Asimo retires, we are solid, and that transplant program will go. We have done 15. Way forward, we are scaling up on living donor program, and next year we are going to begin doing this on our own. We are going to copy from you because we will have become proficient. We are going to do them as and when they arise. We are going to accelerate accreditation of other hospitals other than Mulago Hospital. And then we hope in 2029, in Uganda, deadlines keep shifting, but certainly before the next election cycle, which is 2031, you know, when you embed it into the politics, the politicians are on your side. We will have begun the deceased donor program. Our mantra is transplant surgery on Ugandans, in Uganda, by Ugandans. We've already achieved that transplant on Ugandans. It has now been done in Uganda, but ultimately we want to do it to be done by Ugandans. We acknowledge first and foremost our patients who have trusted their lives with us, the Ministry of Health, which has helped us and has been our support with the bill, with the authorization, Mulago National Referral Hospital, the multidisciplinary teams, both locally and international, and then the other partners like Yashoda and the Manchester Royal Infirmary and the university. Finally, before I thank you, these are my take-homes. Where can we collaborate? You didn't ask me to come here and then I go away. One, we can collaborate in the area of testing, HLA. Maybe we do it in Arusha. We bring all the East African samples to Arusha. Why not? The more the numbers, the more feasible. Two, we can jointly participate in the multidisciplinary team meetings as we assess our patients. We do it online. We can bring on board our East African colleagues to look at these patients. Three, we can benchmark. When Muhimbili is going to transplant, we go there. When Benjamin Mkapa, so that we learn from each other. We can share protocols. In Uganda, we already have the law. When you're going to do your law, why should you reinvent the wheel? You can look at our law and see the things to copy so that they are cutting across. And finally, our team from Manchester has resolved to make Uganda a training center under COSEXA. I forgot that I wear many badges. I'm a fella by exams. 2012, that's when I did my exams in urology. So we want to write a curriculum which is accredited by COSEXA, and then we begin training. Thank you very much.
Thank you so much, Dr. Frank. Two things I captured from you. One is no more referral. Two, teachers and the letters do. Thank you so much. And also regional collaborations. Thank you so much for your presentation. And now we go to our next presenter, who will talk about collaborations, especially in bone marrow transplant. And not else is Dr. Fabio. Welcome, Dr. Fabio, at the stage. So, thank you so much. So, Dr. Fabio is a hematologist at the San Raffaele Hospital in Milan, Italy. He is a hematologist with over 15 years of experience in bone marrow transplantations and gene therapy. He works at the San Raffaele Hospital in Milan, contributing to both malignant and non-malignant hematology units. He leads transplantation and gene therapy programs for the hemoglobinopathies and the curative treatment for the acute lymphoblastic leukemia. He is also committed for expanding access to advanced therapy in middle-income countries through collaborations. And actually, we are already collaborating with him. Thank you so much, Dr. Fabio. So, Dr. Fabio, you have been working with Benjamin Mkapa Hospital for almost now for 4 years. We just want to tell us your experience in Italy, how you succeeded bone marrow transplant with this over 15 years experience. And how do you see Benjamin Mkapa as upcoming bone marrow transplant center?
This works. Okay, so good evening, everybody, and I won't take too much of your time because I think we are all quite, it has been a very long day, and I arrived from Italy this morning, so I didn't sleep last night, so I'm a bit, but it has been a very interesting day, and it's a real pleasure to be here. So the collaboration with the Benjamin Mkapa Hospital started many years ago. Actually, I think the first contact was in 2018, 2019, when we signed an MOU with the HelpTree, which is a voluntary association. And the project started back then, and I think when we decided that together with our friends from Belgium here, most of the people were thinking we were crazy. And I think we were crazy, to be honest, because it was something that, many big institutions tried to establish bone marrow transplant in many places around Africa, but did not really succeed. And I really think that the strength of this cooperation was the fact that from the very beginning we decided and we wanted to work together. and really to learn from each other. So I should thank for sure all the people involved, starting with Dr. Stella and Dr. Shakiru that I see here, that were the very first two doctors with who we started to collaborate so many years ago. So again, you need probably some visionary mind and some crazy minds to decide to create such a project, and we succeeded. What I think is really interesting, seeing it from my point of view, so from one who's lucky. I come from Italy, it's wealthy, rich country, and we are used probably to do even more of what is actually needed. So what I learn when I come here, working with the local experts, is really to do an extreme synthesis to understand what is really necessary. So the idea is really to build and to do a bone marrow transplant unit which ideally will have the same, not ideally, which has to have the same results and the same outcomes that we have all around the world. So we don't want to do, cheap transplant. We don't want to do transplant that are not effective or not safe for our patients. But what we try to do is to try to understand, starting from the knowledge that we have, what is really necessary. So it doesn't mean not doing what is in the interest of the patients. It means deciding where we should really allocate the resources we have in order to have still safe and effective treatments. And so it has been an extraordinary journey with many people involved, many colleagues from Italy, many colleagues from Tanzania. I'm not going to name them all, but I see all of them around. And so really I want to thank all the people from BMH, because it has been definitely one of the most inspiring experience of my professional and private life as well, because I learned a lot from you, so thank you.
Thank you so much, Dr. Fabio, for those explanations. Very interesting and giving the hope for the future. Can you tell us what went well and what went wrong along this journey?
So what went well was definitely the group effort. So I think you need also some luck, and I think we were lucky because we really somehow liked each other, and that helps when you need to work in a team. And really, as many people have said today, bone marrow transplant, all transplant altogether, are a multidisciplinary team, and it's a team effort. It's not something that you can do by yourself. And what I think what worked very well was actually the will and the desire to work together, involving all the different professionals involved, from nurses, doctors, lab people, blood bank specialists, so forth, so on. So this was really, really good. And the family and the children, they were amazing, and I've never seen such committed families and children. Always, really willing to participate and to be part of the teamwork, and I think this has been amazing. The major issue still remains, as we've said many times, the sustainability and the procurement of many materials, drugs, devices. And what I want to underline here is that I don't think that it's only related to money, but it's really related to the fact that the supply chain of many of the drugs we need and of many of the materials we need virtually does not exist in East Africa. So it's not only a matter of money, but it's the fact that you cannot really find those drugs, and you cannot really find those materials and those devices that you need. So I think this has been the major challenge. And as it was said, I think that working more with private companies, and ideally now, if new other BMT units will be in the area, I think this will be very beneficial, because creating a network will also create a market. And so finally, the company will also, be happier to come and be at this and give drugs and bring devices, because finally there are hopefully many bone marrow centers. And so that's why I think, being the first, it is complicated because nobody was trusting us. And so when we were asking, the companies, I won't do names, that we need this drug or this drug, people were like, this is not happening in Tanzania. But now that we've shown and you've shown that this can happen, I think now finally we are also seeing that from the private sectors, people are actually listening, because it was not possible to involve them 5 years ago. They were like, okay, yeah. When you've done some, then we'll be in touch. And I really think that, a network of centers will be very beneficial for the training, for sharing knowledge, for sharing the supply chain. So it's really important.
Thank you so much for sorry for taking too much of your time. Last, what do you think is, what do you propose the way forward as we move forward with this, our partnership, as now Benjamin Mkapa is conducting its first organ transplant symposium, but also we are proceeding with bone marrow transplantations. What do you think should be? How?
So, you see, there are many things that will be very interesting to do. Definitely, if we concentrate on sickle cell disease, expanding the availability of donors to different donors, so haploidentical transplant will be, something that we could think to implement. Or on the other side, also moving to offer transplant also to different, for patients with different disorders. All of these, both ways I think are really relevant. They require extra work in terms of infrastructure, of implementation of technique, because as we've said a few times, at the moment we are doing, the easier transplant, HLA identical, bone marrow, kids. When you start doing a more complicated transplant, you need a bigger and a more comprehensive setup. So the challenge here is to work together to establish that setup.
Thank you so much for your response. Thank you so much. You can have your seats.
A round of applause for Dr. Fabio Giglio from Italy. A round of applause for Dr. Shija Kesi for running this session. In the interest of time, we are adjusting a few things to make sure that we get out in 30 minutes from now. First of all, scan the barcode. It is a feedback for this conference. Tell us where we did well, where we did, but be honest so that we improve next time. Number two, on behalf of the entire Secretariat, Dr. Makani will summarize Professor Makani will summarize our resolution and she'll come to explain here, and we will go and write them as one of our conference resolutions. Dr. Jessica Shabano, a Director of Medical Services, will run a very final show of our sessions today. He will lead the presentation for coronary transplant. He will read the presentation for research and the transplantation. And lastly, if you have a patient anywhere, how do you refer that patient? Dr. Jesse, iko hapo chini nyuma kabisa ya microphone hapo, then you can continue. Switch it on hapo, and then you can continue. Karibu sana. Makofi tafadhali kwa Dr. Jesse.
A great evening to you all. We've been sitting for quite some time, so I would advise we stand for 1 minute while we're taking this time to welcome on the stage Dr. Sandy, MD. Dr. Sandy is an ophthalmologist and an academic leader at the University of Dodoma and Benjamin Mkapa Hospital. He combines clinical care, research, and advocacy to advance high health in Tanzania. A national advocate for cornea donation, he promotes ethical and sustainable pathways through community engagement. His work is strengthened by collaboration with international partners, supporting the development of corneal transplantation services and efforts to reduce corneal blindness nationwide. Please welcome Dr. Frank Sandy, and he will be discussing corneal transplant. We may all get seated. Thank you. Welcome, Dr. Frank.
Okay, thank you, Dr. Jess, for that kind welcoming. So you have been hearing about kidney and bone marrow, but I'm going to shift a little bit on the eye. So when I saw the advert for this first organ transplant, I said the eye should also not be left behind because it's small, so if you don't come up and speak for it, probably you might not receive any attention for it. Okay, so my talk, I'll just be very brief. I know you're tired, but just pay a little bit attention. So as we are moving to a roadmap of organ transplant in Tanzania, and now I'm talking about the future. So my session is given a title of A Gift of Sight, Building Tanzania's Future in Cornea Donation and Transplant. So why does it matter? We know that in every blind person, there's a story or dream which is interrupted. And all these people who are being given back their life from kidney transplant, from bone marrow transplant, they eventually need to have good sight so that they can become productive in the society. So the cornea blindness affects a number of people, and we have seen there like 25 to 30% of bilateral people who are blind, they are suffering from cornea-related problems. And cornea transplant is one of the most common and successfully performed kind of transplantations worldwide. And these pictures show some health cornea and the cornea which have a disease. During break, I was discussing with one of the colleagues, and he was telling me, he was asking me actually where the cornea is, and I was just trying to explain. So I thought before I move further, it's better I just explain what the cornea is before people leave here with different opinion. So the cornea is like the windshield of a car. It's the front part of the eye. And you can see it's simple, but it's 6-layered structure. And the main role of it is to refract. So without refraction, your vision will be impaired. And when it's structurally impaired, usually your vision is compromised because of inability for light to pass through. And the human face of cornea blindness, I think we all know that a child will not be able to start or to improve himself if he or she doesn't have good vision. So when we're talking about vision, we are talking about productivity, we are talking about economies, we are talking of parents of kids who cannot be able to see. And these are not just statistics, these are our people, they have vision problems. And when we talk about cornea transplant, it has and this is, I think, is where most point where we can leverage on diseased donor, because you cannot donate your cornea when you are alive. You have to be dead to donate your cornea. So cornea donation can do a lot of things. They can restore sight, dignity, restore independence, because these people who doesn't have good vision, they usually depends on their kids or their relatives to give them care. And the good thing is one donor can give a second sight to 2 people, because we usually commonly donate just 1 eye. So if you have 2 eyes, we can give them to 2 people. So you can give sight to 2 people who need the sight back. And what's the reality in Tanzania? Hundreds of people, they are waiting for cornea transplant. And these are just statistics I obtained from our hospital, from KSMC and the Muhimbili National Hospital. And mainly we've been depending on on imported tissue. And between the year 2018 and 2021, we had only 98 transplanted cornea. And these were mainly from people who came with the corneas in Tanzania. And the main hurdle is that we don't have any active eye bank in Tanzania. And so we don't have enough stock of corneas in Tanzania. And the power of eye bank, on the right side, that's when the Benjamin Mkapa was starting. That was, I think it was 2013. So in the span of 10 years, we have done a lot of activities. And I believe if we incorporate cornea transplant or cornea banking as one of our agenda, we are possible to establish an eye bank in Tanzania. So we have been collaborating with some partners, and we have been working with the Moran Eye Center and Well Cornell, which are based in USA, and also the Lions First Sight Hospital in Kenya, which they have an eye bank, and they've been doing well. So this could be a model to show what is possible in East Africa. We have seen Benjamin Mkapa and UDOM. Some people have been calling them identical twins, and yes, they are. So we can collaborate and be like a first center for cornea transplant and cornea bank in Tanzania. And I believe given the right management and the spirit we have, it's very possible to establish an eye bank in Tanzania. So we all know we've been hearing a lot about community involvement, and Dr. Thomas just talked to us about trust. So the first step in donation of organs is the trust. And once we have the same voice, faith leaders guiding the understanding of donation or donating your organs, politicians raising awareness. We know in Tanzania, as in Uganda, we link most of the stuff with politics as well. So families giving consent with pride, like I donated my eye, I donated my other part of the body. I think this is the way we really want to go. And the communities can embrace donation as a final act of love, because if you die with your cornea on place, I think it's an act of selfishness, rather than giving it to someone who needs it and is still alive on the earth. So there's some myth and ethics and silence I know behind every transplant. We have been heard a lot about opt-in and opt-out, and we are yet waiting for a policy which the CMO promised us probably September this year. We'll have a transplant policy which can dictate all this. And these are some of the theories or myths surrounding the donation. Like if you start discussing the end of life, the relatives might see maybe madaktari wameshamkatia mgonjwa wetu tamaa, but in really sense that's not what it really means, but it's just giving another person a chance to survive when he is still alive. So silence is our biggest barrier, and I think we need to break that. And most of people really don't know if they can donate part of their body during the end of life. So we are planning to establish the hospital-based donation, and I think this is where it all begins, because recently statistics show that 30 to 40% of all deaths occur at health facility, and all these people can be potential disease donors. We've been seeing the previous presenters. And we need to build a system where we can have respect, ethics, and humanity. Because we are told the first step in donation is trust. So if the community trusts us that the organs they're giving us, we're not doing for business or something else, we can change the way we operate. So the vision for Benjamin Mkapa and the UDOM, I think it's we can be like a national center of excellence, and they can also training for hub for ophthalmologists and technicians, and it can be a reliable source of high-quality corneas, because the issue now is obtaining of corneas. And there's a very big scarce, because for every 70 people who need it, we have only one. And this mainly is because of the awareness. Most people don't know if they can donate their cornea once they are having the end of life. And I think this legacy will live in generations to come, and it will also be what we left on earth. So maybe we can skip this one. So our shared responsibility, I think, mainly is for clinicians and medical personnel who are here. It's to educate and to advocate for cornea transplant and other organ donations. Policymakers is to support and regulate. As the previous CMO has spoken, when the law comes out, probably it will make a lot of changes, and probably it will be very easy to obtain these organs. And communities also, they need to embrace donation as part of act, as I said, when they're living this on earth. And also the media people, and Andishu Abari and the other guys, they could also do some community education and promotion of donation before when someone is still alive, as if we choose the opt-in options. And I think together we'll be able to build a system that honors life and restores vision, because this is all what we were called for. So we are just calling to action so that we are able to establish the cornea bank and the organs bank in Tanzania. Just know that sight is not just a sense, it is a future. Because if someone doesn't have a sight, even the production, the way he or she operates, really becomes impaired. And a donated cornea is a final act of love that lives on another person's eyes, because this person will keep on remembering you for giving your cornea. And as Benjamin Mkapa has been a daring institution, I think we are possible to build probably the first eye bank in Tanzania where we can restore sight and hope. And as I'm concluding, maybe this is a call to every one of us who are here. Probably you have never known that you can donate part of your body during your death. So I invite every one of us to reflect on the extraordinary power we are holding. The power to restore sight, to return a child to school, to give a parent back the ability to see their family, to return dignity to someone who has lived so long in darkness. And cornea donation is not merely a medical act, but it's a profound expression of humanity, compassion, and legacy. It is a gift that outlives us, a final gesture that continues to shine long after we are gone. So as we said, charity begins at home. I think most of us here, we can be part of the cornea donors. And we have come up with these badges where we are trying to promote awareness among us. And this badge reads recycle yourself, be an organ donor and cornea donor. And you have them there at the reception, the front desk. If you want, you can take one and wear it so that you kind of promoting more people to donate their organ and their part of the body. And the last phrase said, are you ready to let your final act on earth become someone else's first glimpse of light? Because there are people who really don't have vision, and when they get back to your cornea, they can really appreciate and go back to their work. And again, for those who are new in Dodoma, Dodoma is known for grapes and in its many forms. But you can grab one of the grapes and don't leave Dodoma without grapes. After saying that, thanks a lot for listening.
Thank you. Asante, Dr. Frank, for such a wonderful presentation. And also, I've been thinking, sasa unakufa na konea, uko chini unaenda kuona, unataka ukaone nini? It's an act of humanity. Let's do so. Thank you again, Dr. Frank. And now I take this time to welcome Dr. Emanuela Ambrose, who is a pediatrician, hemoglobinopathies specialist, and senior lecturer at Bugando Medical Center and the Catholic University and Allied Sciences in Tanzania. She's a leading clinical researcher in sickle cell disease, driving innovation in comprehensive care, including disease-modifying therapies. Her work integrates clinical excellence, translational research, and capacity building to strengthen sickle cell disease care systems in resource-limited countries. But also, Dr. Ambrose is committed to advancing equitable access to sickle cell therapies and improving survival and quality of life for children with sickle cell disease across the sub-Saharan Africa. Welcome, Dr. Emanuela.
Asante. Good evening, everyone. Thank you, the organizing committee of BMH, for inviting us. I'm with my colleague, Dr. Said, from Bugando Medical Center. So I'm glad that I have role models here. I learned from Dr. Julie McCann ever since my residency, and now I graduated my PhD last year under the supervision of Abel Makubi, so I'm really excited to be here. Asante. So I'm taking you through referral pathways as I will take sickle cell disease as a model for this, and I know other organ transplants will have the same pathway. So this all is to improve access to hematopoietic stem cell transplantation or any other organ transplantation in Tanzania. We have seen and heard that sickle cell disease is very prevalent. In Tanzania, we are among the leading countries. And mortality is very, very high if there is no intervention. Tanzania have started doing pilot studies on newborn screening, and now we have started seeing these children very early and initiating them on management. After we screen them from birth or from clinics where they get their injections for vaccination, is when we link them to care and initiate them on management. The government of Tanzania have made sure that they build health capacity to healthcare workers, and when these children comes to us, we initiate hydroxyurea as per sickle cell guideline that is on place. And we make sure from 9 months of age, all children are on hydroxyurea. So with this building continuum of care, the huge progress now we have seen is bone marrow transplant and the future gene transplant that we expect coming on the way. We understand that hydroxyurea have made a huge benefit in sickle cell disease. Apart from increasing the fetal hemoglobin, it has a lot of benefit to sickle cell disease. So if you see this, for those hematologists who always see the slides, you can see these are red blood cells that are very distant from one another. When you start hydroxyurea, the cells are very populated, means the hemoglobin is increasing. And increasing further the dose to the optimization, you find the cells have increased in size, and even the children or those patients who are using hydroxyurea benefit so much from this drug. And hence, if you benefit well, then you live well and attend well to schools. But with all these benefits from hydroxyurea, there are those few people who don't respond to hydroxyurea. I'm taking this as an example from my PhD study. You can see from the picture on the left side, this lines shows all children who were on hydroxyurea. And the green and yellow lines below the TCD change centimeter per second, those are children that responded very well to hydroxyurea. But there is this one who persistently had a high velocity. And children like this, who have high velocity, despite hydroxyurea dose optimization, means they need another alternative for treatment because they have poorly responded to hydroxyurea. Other issues, other diseases or complications like recurrent vaso-occlusive crisis or transfusion dependence also will make you need another therapy. And what we have in our country currently is a bone marrow transplant for sickle cell disease. So we start our referral journey from the dispensary or primary healthcare facility, where we diagnose our children using clinical presentation. And when they reach further to the health center is when they can start having labs. They can be screened with point-of-care diseases. When they advance further to the district hospital, they get further investigations, and when they reach to the regional referral like Bugando Medical Center or KSMC, they can even reach further to the advanced screening of advanced infectious screening or organ function assessment, donor identification, and even eligibility confirmation. When they reach to a hospital like BMH is when they can confirm the HLA match and they can have their transplant procedure. But what are we supposed to know? That this regional referral hospital is the one that can evaluate these children well because they're well equipped in terms of diagnosis. So when the child or parents shows there, we have to identify severity of the disease, and if the patient does not respond well on therapy is when we can optimize the medical therapy to make sure they are well, we optimize dose, and we give them supportive care. When they don't respond well is when we think of early referral to the transplant center because they're now eligible to transplant. We have to do this referral early before severe complications occur. So majority of our patients, they get late referral. and hence they miss opportunities for curative therapy. And by missing this opportunity, presenting themselves late, they get there with advanced complication or without a proper wake-up from the referral center. Hence, they become ineligible while they've traveled so far to come direct to BMH. So if the regional referral is able to do all this investigation, then we will solve this issue of patients to be screened well at the center. So there are several gaps from the system level. We need to screen our patients early so that we can identify them well with a disease and any complication, and we should increase our diagnostic capacity from the system level. From the provider level, we need to diagnose early in order to avoid the delayed recognition of the disease. And from the patient level, there is financial barrier that we have heard, and also the patient delay care seeking because of different reasons. Most of us spoke about HLI matching challenges, and we really see this. Many patients come here and they don't match. So we need to find a suitable match in families, but many patients are the firstborn, so they have only one kid, they lack the match. So there is an option of finding other options of finding matches, like to find other half match, like a parent. And by saying so, we need to strengthen BMT access in Tanzania, starting from early identification of the disease, optimizing the referral route, and expand our access to transplant by improving coverage of the insurance and also international partnership from other institutions who are doing better, and also local transplant capacity expansion, like I've heard KSMC is on the way, and expand the donor option. So that's Bugando Medical Center, and the two pictures on the left side is our first organ transplant, that was kidney transplant, that was performed this year by the team. Thank you so much.
Asante, Dr. Ambrose, and I'm glad to learn that you are Professor Makubi's student. I hope you'll be able to share the story of how was your PhD journey with the colleagues. I know you passed through Professor Julie Makani. You have had a lot of stories, I think. And now let me take this opportunity to welcome Dr. Mgolelo Grace Matt Mabusi. She is the head of Grant Management Unit at the National Institute of Medical Research in Tanzania. She's a public health scientist and an epidemiologist with expertise in implementation science, program management, health advocacy, humanitarian health, and community-centered health intervention. Her work focuses on infectious disease, epidemiology, sexual and reproductive health, and advancing health equity for vulnerable populations. She also brings a synergistic blend of research, leadership with strategic management and coordination. Today, this evening, she'll be discussing about research in transplant services. Earlier on, during this presentation, Professor Julie McCann posed an important question on the role of research in improving these services. I hope she is going to answer some of this, and Professor, you'll be pleased with our presentation. Please welcome again Dr. Mabus.
Thank you very much. Thank you for the nice introduction. Dr. Mgole Grace, the head of the Grants Management Unit from NIMRI, Tanzania. And I would like to just bring a presentation that is just involving all of us brainstorming the roadmap to organ transplantation in developing countries. So just a brief introduction on NIMRI's mandate. we basically carry out, control, coordinate, and register, monitor, and evaluate and promote health research in Tanzania. So we promote scientific and ethically sound, high-quality health research. And it's also established as a parastatal service organization under the Ministry of Health with dual functions in regulation and scientific implementation. So the NIMRI's song, as of the moment, is DIRA 2050, which is the impact vision of 2050, which looks forward for a nation that embraces evidence-based decision-making, driven cutting-edge scientific and social and action research, and also a robust research and development ecosystem, with including developed sustainable financing mechanisms. So coming to the background of why transplant matters, 173,000 organ transplants were reported as in 2024, and kidney transplant remains the largest transplant category, and access to is concentrated in better resourced health systems, but health equity is the core challenge as of the moment. So taking a look at this art, it was painted by an Italian artist, Fra Angelico, in the 16th century. As you can see, these are two physicians, twin physicians, which, Cosmas and Damian, trying to do transplant from a deceased Ethiopian patient, as you can see from the color of the skin. So what does the picture tell us? It's at this moment, most of the developing countries envision advanced organ transplant as something that is beyond reach. And as we can see, what history teaches us is medical progress is still moving forward, because people are able to imagine things that are still not yet to be implemented, but they later come to establishment. So what does this call give us? It gives us the opportunity to not only think organ transplant as a clinical practice, but also to make sure we design and develop a scientific foundation whereby organ transplant is accessible, is ethical with equity, and at the end of the day, it's sustainable in the country. So I would just want to go as fast as possible because I have limited time. So these are the three areas that I would like to just touch a bit, which is, the first one is research data and evidence. So as we envision research in organ transplants, we expect to see areas in National Transplant Registry and data systems, because with the following components, this is going to give us an opportunity to actually develop the program and track the outcomes, identify gaps, and justify investment in the near future. And also, in regards to the burden of disease, as we can see, 43 countries have major treatment gaps in terms of organ transplant. Health economic and financing is an important aspect, whereby we should check cost and transplantation and immunosuppressive drugs research, because at the end of the day, as much as patients are undergoing organ transplant, they're in a burden of having to take immunosuppressive drugs for the rest of their lives. So also out-of-pocket expenditures, productivity loss, and household financial burden. So these are just the areas we can look forward to when it comes to health economics. The second aspect is ethics, clinical and systems research, whereby here we just look at the local evidence, because most of the evidence is from the developed countries, but having the local evidence will bring about public trust, religious beliefs, consent systems, and donor family decision makings, and risk organ commercialism. So this will give more of inputs in our local personnel. on how to navigate and make sure that they don't enter in any commercialism and undermining in the entire system. So this is also part of the clinical research, whereby we can develop labs, and our hospitals can also be hubs for clinical trials. At the end of the day, we want to come up with locally developed clinical protocols and guidelines that account for resource constraints, different disease patterns, and patient presentation lifelines in developing countries. So going to the infrastructure, workforce, and implementation. This is still speaking about the platforms and the labs, which is actually the backbone of both clinical care and research. So we should enable accurate diagnosis, appropriate donor matching, and longitudinal outcomes after having to do this particular research, and enabling strong labs that really accommodate such type of data. When it comes to workforce, I think we have different multidisciplinary specialists, and all play a major role in bringing about research output. And these are also the training priorities, whereby NIMRI also plays a major role. And at the moment, we have around 90 MOUs with different hospitals and institutions in Tanzania, and we actually welcome more of them to help in providing appropriate training. So the last aspect is implementation science, because at the end of the day, we need to bridge the gap between evidence and practice and ensure that proven interventions reach every patient who needs them, regardless of their geography and socioeconomic status. So these are just the contributions. Yeah, asante sana.
A round of applause for Dr. Jesse as he finishes this session. Thank you for surviving for this entire day. A round of applause for everyone. I understand it was not easy, but through your dedication, profound interest into the subject matter at hand, you persevered all the things that had happened. It's time now to wind up the ceremony, to start the closing ceremony and wind up the conference. So first of all, I want to recognize the support that has been provided by Mr. Anderson Kilovere. Where is he? Anderson Kilovere? He's out. Anderson Kilovere, he is out for coordinating all the presentation. I want to extend sincere appreciations to Dr. Stella Malangahe for coordinating the timetable. In a very special way, I want to recognize Dr. Shija for connecting with important speakers. In a very special way, I want to, all of us to join our hands together for Dr. Ngolo and her team for recording and transcribing all of what has been transpired. And she engineered the availability of all the details that were provided to the speakers, especially the guest of honor, His Excellency Dr. Grace, and other speeches. She provided the ingredients and they were able to build from that. Thank you very much for your team. I want to recognize the work that has been done by Dr. Happiness Igogo. Dr. Happiness Igogo, she was the secretary of this organizing committee, and at some times she performed the duty of a driver. She picked up some of the important speakers at the SGR to the lodging station, to the lodging hotel. Makofi tafadhali. On behalf of all moderators, Dr. Meremo, Dr. Jesse, Dr. Baja, and many others whom I can't mention their names because of their list, not because of not important. I want you to put your hands together for them. I want to put also you to put hands together for all the speakers, those who were in the panel, those who presented online, those who presented virtually, those who presented live, and those who spoke here from the podium, like Fabio Giglio. Makofi tafadhali. In a very special way, I want to thank all the keynote speakers who has been given the opportunity to test how vast they are, to accumulate all the knowledge from all literatures, to condense it to an extent that we could have a 5 to 10 minutes presentation. So thank you very much for Professor Julie Makani. Thank you very much for Professor Mwashambwa. Asanteni sana, all delegates from wherever you came from. The first symposium is coming to an end, but it was not so if we were not supported by University of Dodoma under the leadership of Professor Lugano Kusiluka and the Executive Director of Benjamin Mkapa, Professor Abel Makubi. Makofi kwao tafadhali. This symposium was one of its kind. Yes, it was first, but not last. It is the beginning of many more that are about to come, with more delegation, with more topics, with more time management that we felt today. We will improve next time. And we'll include other speakers from other continents, including the America, North and South. Thank you very much for bearing with us in all weaknesses that you saw. 7 countries have been represented: South Africa, India, Italy, Japan, Uganda, Tanzania, and those people who came from Dodoma. Asanteni sana. It's a capital, so when you're talking about Tanzania, it's here. We were sponsored by a different organization. We want to join our hands together for all the sponsors. Delegation list was coordinated by Irene, Catherine, and Dr. Peter. Makofi tafadhali kwao. Dear friends, you might witness that we had Dr. Grace Magembe, but we also ate. We also took some bites, cakes, and many other things to fill our body as we fill our mind with the entire knowledge. Asanteni sana. This conference has been attended in total with delegates of 180. 120 persevered to the end. Evening tea is served to around 100 people who will be listed to be the people who have concluded this symposium tonight. So makofi tafadhali kwa uvumilivu wenu. We had 7 universities to include University of Dodoma, KUHAS, MOHAS, Aga Khan, Makerere. We had 2 national hospitals, Muhimbili National Hospitals and Mulago National Hospital. Dear friend, it has been well attended. Asanteni sana. From Tanzania, delegates come from all over 20 regions. We had delegates from 20 regions. Makofi tafadhali kwa delegates wote. Major stakeholders, including the Ministry of Health, Institute of Research, Insurance Company, MSD, Transfusion Department, and these key other stakeholders, including trainings and organizations like that of Dr. Soka and many others. Asanteni sana kwa kuja. Your brain now goes home with the 24 subtopics that have been presented in this symposium. This is an output. The Medical Association of Tanzania will award up to 8 CPD points for your licensure and improvement of service at your workstations. Makofi tafadhali kwa association. Way forward, we will write a proceeding that can be published in reputable journals. So those who have not submitted their final abstracts, please finalize and send them within 1 week after the completion of this session. We will follow up on you so that we have a proceeding that can be published in reputable journals. Another way forward, this is an important moment to forge meaningful partnership and collaboration. Tonight, 20 people, Mr. Alex, 20 people has confirmed for liver transplant dinner at the destination that we'll announce. That's the beginning of our collaborations. I understand a glass of wine again might be supplied. Be there. Lastly is the conference promotion, so that we set the impetus and the bedrock for the upcoming conferences. We ask you all delegates, you will receive a copy of many photos we have taken here. Kindly push them in your social networks. It is important, it pays, as we engage the community and those who didn't appear here in this conference in person. We understand it was live streamed, but with your WhatsApp post, Facebook post, status updates on all social media under Meta, we want you to be able to post that. Dr. Frank Sandy has dished out some of the badges that promote coronary transplant. For those who are interested, make sure that we meet, and some of you have been receiving as our ushers are passing by. After having said so, ninaomba sasa nimkaribishe mkurugenzi wa hospitali ya Benjamin Mkapa to shake hands with the few on our behalf so that we save time. He can be accompanied by Dr. Baja and Dr. Jesse and Dr. Shija on behalf of others, and Shakilu to shake hands with our delegations. You can come here upstairs. We will start with certificates. Our first certificate of appreciation is delivered to none other than Professor Julie Makani. Asante sana. Some years ago, it was Professor Julie giving Professor Makubi something. Today, I have the honor to call Dr. Raghavendra Babu to receive a certificate of appreciation. Yes, evening tea will be served right after here. I have the honor to present this certificate to Dr. Clara Chamba. The next certificate is presented to Dr. Frankie Asimwe. Ladies and gentlemen, we have the honor to present certificate of appreciation to Dr. Ebun Bamgoe. Professor Masumbuko Mwashambwa is the next. Dr. Frankie Sandy comes next. Your Excellency, Professor Abel Makubi, I now ask you to present a certificate of appreciation and recognition to Dr. Shija Kesi. These are our people, and we want to write history with their names written. Thank you very much. Your Excellency, Professor Makubi, I ask you also to handle a certificate to Dr. Shakilu Jumane. And the last certificate is handed to Dr. Mugisha Nkoronko on behalf of the committee. Wanasema kazi na dawa. Nimepewa dawa kushukuriwa kwa niaba ya kamiti yote wakati wa kazi. Asante sana. Your Excellency, bado dakika moja. Niombe as a sign of souvenir that you will take it to your home on behalf again of everyone who has attended, everyone who has spoken here. His Excellency, the Executive Director, will dish out the souvenir to Dr. Ebun Bamgoye. The second one will be to Dr. Frank Asimwe. And the last one is to Dr. Fabio Giglio. Oh, and as a souvenir, Dr. Fabio, you can take your certificate again. Dr. Fabio, your certificate too. And the last one goes to the student of Professor Makubi, who is within this room, who was supervised by Makubi in her PhD, Dr. Emanuela. Asante sana. Baada ya kusema maneno hayo, all the delegates on the stage, you can resume your seats. Asanteni sana na makofi tafadhali. Asante. Mwanzo wa sherehe ya transplant ya pili umeanza. Hata hatujafanya ya pili tunaanza kusherehekea.
That all the transplant services have not been possible if we do not have partnerships from within Tanzania and outside of Tanzania. And so we recommend a systematic way of strengthening partnerships and collaboration, exchange programs, as well as partnerships with industry and the private sector. That's the third one. The fourth resolution or recommendation is really community engagement and patient engagement. We're really grateful to Shani and her daughter, to the patient who received kidney transplant, because the voice of the patient in being able to share their experience is very, very powerful. And we look to patients and the community as partners in this area. So what is the most systematic way of encouraging those community engagement? The fifth is research, and you heard from NIMRI as well as throughout this symposium, the importance of research, basic science research, clinical research, implementation research, health systems research, and we hope that this will strengthen the transplant programs in Tanzania. The sixth is really the importance of policy and financing. We know the cost of this to the government of Tanzania, the cost of transplant to patients and communities. And so how do we work together with the government to make sure that the appropriate policies and financing frameworks are put in place? The final resolution or recommendation is the establishment of an association or a society for transplant. We think that this symposium, bringing together bone marrow transplant and renal transplant, corneal transplant, and now liver transplant, is really the beginning of an association for transplant, and this will bring all stakeholders together from all fields. So these are the 7 recommendations, resolutions, and we would like to welcome you all to contribute to improve this before we submit this to the Ministry of Health and the Chief Medical Officer. Thank you very much.
By show of hands, how many agree that this should be our resolution? Thank you. This is our commitment that everybody is going to work on. These are our milestones, will be defined by this growth. This is what we will be working on earth until we fulfill them. We'll be judged by the degree of implementation when we meet in the second resolutions. Kindly keep them to your heart. Put it on your desk. Work with it in your every places you are working and work toward its fulfillment. Last but not least, I have the honor to welcome Dr. Thomas Ruta Chunzibwa to come and deliver a final word of remark and declare this symposium closed.
Habari za jioni. May I recognize the presence of Professor Makubi and Professor Makani. Ukimtaja babu lazima mtaje na bibi. And may I recognize also the presence of all delegates from within the country and outside the country. On behalf of the Regional Commissioner's Office, particularly the health team which I am leading in this region, may I take this opportunity to thank the entire team for this good day. We have been here since morning, sharing experience on what we have been doing, particularly at Benjamin Mkapa Hospital for the past 10 years. This event is one of the events which have been organized as we are leading to the celebration of the 10th anniversary of Benjamin Mkapa Hospital. I take this opportunity to congratulate Professor Makubi and his team for the good work which have been done so far. When we started this hospital 10 years ago, it started at the infancy stage when we compared with the other zonal hospitals in this country. At that time, we had 2 specialties, but to date,